Hello, everybody. Welcome back to the Incubator podcast. We are back today for an episode of Journal Club. Daphna, good morning.
Good morning. How are you?
Very good. Feels like our Journal Club spot has been stolen by so many other good episodes.
Yeah, right. We're reviewing very important recent journal articles, but it's been keeping us out of reviewing
What's
journal
interesting about
articles.
this is that people think that we are sort of the nerds of the neonatology world and that we're always reading. But what's interesting is that when we have people who come on to do the review of the recent literature, whether it is the team from the Neonatal Nephrology Collaborative, whether it is the team from the Newborn Brain Society, I invite you to go listen to these episodes because it's great to have these experts review content specific literature. Like, it doesn't mean that in the background I'm reading more and more. I slack off. And so
Well, it's why we started the podcast,
I
right?
know,
Because we
but you would
couldn't
think
keep we
you
couldn't
would
keep
think that if
ourselves
without
accountable.
the podcast now we would be still no, if that calendar is invite is not on my Outlook, then yeah.
We
I,
fall
I
behind. So we feel from the community, everybody who's having a hard time keeping up with the literature on their own. But I second what you said. I was thinking this. I listen to every episode, even the episodes that we record to remind myself, what we talked about, what are the takeaways, what are we learning? But these year in review have been really good. I learned a lot. I'll say just from the nephrology year in review, already I've sent many times to many colleagues and used in the unit those resources. So, I hope people take a look at our summer offerings.
That's something that we that really came, in my opinion, from our time at CHNC. I
Yeah.
think that CHNC is a venue where you go and you interact with a lot of subspecialists that you just maybe engage with as consultants, but the idea to see them as partners and collaborators, and that these are the type of people that also think about your babies. They think about
Yeah.
these preemies after they leave the NICU. I think it prompted us at least to say, hey, like we wanna maybe share a little bit of how do you think about these things. And if we know how they think after babies leave the NICU, we are better at counseling families while they are still in the NICU. And the kidney is a big deal. So many of our babies do have some degree of kidney injury because of their PDA, because of their inherent physiology. The brain, I mean, come on, like, we don't even begin to scratch the surface of how babies' brains are affected during the NICU stay. So
Yeah,
it's interesting to get that perspective for sure. All right.
totally.
We have an EBNeo segment today. We are very happy to welcome one of the Incubator team members on the podcast, Dr. Gabriel Altit from Montreal Children, who's going to review the impact article of the month for the EBNeo team. So stay tuned for that. And without further ado, I think we are ready to begin.
Let's do it.
I'm going to start today with an article that I found in The Lancet. It's by first author Luciana Teofil. It's published this year, and it's called Cord Red Blood Cell Transfusion for Severe Retinopathy in Preterm Neonates in Italy, a multi-center randomized control
A
trial.
very cool
This is the
study.
BORN trial. Okay, so red blood cell transfusions are a common part of neonatal care. We know that particularly when we're talking about LGANs, also known as extremely low gestational age neonates. Now, these babies often require repeated transfusion early in life. We're trying to identify guidelines that would help us reduce the amount of blood they're exposed to. But one of the things that we talk about a lot is the idea of this rapid transition as they are born from their fetal hemoglobin to more of an adult type of hemoglobin HbA, which happens after birth, and that we are kind of accelerating with the process of transfusions. The authors mentioned that there are several studies that have linked lower levels of fetal hemoglobin with the development of retinopathy of prematurity, or ROP, and that hemoglobin F, fetal hemoglobin, has properties that may actually protect preterm infants. It has a higher oxygen affinity, it has greater nitric oxide availability, and better oxidative stress resilience. Now, with that in mind, this study asked a critical question, which was, what if we could transfuse this particular cohort of babies with cord blood derived red blood cells, which contain fetal hemoglobin, instead of your standard sort of adult PRBCs? Could this potentially
Very
reduce
cool.
the incidence or severity of ROP?
Love it.
Yeah, it's a great question. And so this is what the BORN trial set out to investigate, whether transfusing babies with cord blood-derived red blood cells instead of adult red blood cells would reduce the rates of ROP. Um, Now, one of the things that I want to highlight is that we're going to go through the methods, and I'm gonna go over some aspects of that. So it's a prospective, randomized, multi-center, double-blind control trial conducted in 8 Italian NICUs between 2021 and 2024. The eligibility criteria were basically preterm neonates born between 24 and 27 and 6 weeks and 6 days, and they excluded babies that had maternal fetal immunization, high drops, congenital malformation, prior transfusion, hemorrhage, and congenital infections. Babies were randomized 1-to-1. The control arm received adult donor RBCs, and the intervention arm received cord blood derived RBCs. They put twins in the same arm, and randomization was stratified by site and by gestational age using permuted blocks. Um, The intervention lasted until about 29 weeks and 6 days post-menstrual age. Cord blood-derived RBCs were obtained from a public cord blood bank and processed within 48 hours of collection following a standardized national protocol. You can go through the section on methods and see that actually they had an intimate involvement of the blood bank, which they're always so nasty to everybody else. So the fact that the blood bank did cooperate with this particular process and was the one generating these pouches of RBCs was quite neat. The outcomes that they were looking at, the primary outcome was the incidence of severe ROP at discharge or at 40 weeks postmenstrual age, whichever one came first. And they defined severe ROP as stage 3 or higher in zone 1 and 2, and or the presence of plus disease. They had a slew of other secondary outcomes, the rate of ROP requiring treatment, the incidence of BPD, composite outcome of death, severe ROP, BPD or NEC, transfusion-related measures, and so on. Now, what's interesting is that initially they designed, and I think this is why it's important. We don't often spend time on statistical analysis of the different papers because a lot of the time it's done very well. But sometimes it's so interesting about like how do we go about answering a question. So I want to spend some time on the statistics of this paper because this study was initially designed as an intention to treat analysis. And the study had to contend with a lot. So and the intention to treat analysis means that once randomized, always analyzed. And the problem with intention to treat is that if you have protocol deviation, then you still do not move babies from one arm to the other. And this is a study that, as we'll see, it's hard to get cord blood, red blood cells. And if a baby needs a transfusion, guess what? Like the team is not going to just say, no, you're going to stay very anemic and symptomatic, and we're not going to transfuse you because we're waiting for that pack of cord blood derived red blood cells. So there was a lot of protocol deviation. And so to handle this, basically what the team did is that they added 2 more types of analysis. The per protocol analysis, meaning only patients who received their assigned product before 30 weeks, and then an as treated analysis where they basically looked at the groups based on what they actually received. The sample size was calculated to detect a significant reduction in severe ROP, accounting for gestational age strata and a 15% mortality rate. And so they basically landed on a power analysis that dictated a need for 146 subjects. So I think it's always interesting to read the statistical section of these papers because you will see how understanding this basically helps you analyze the results of the paper. So let's walk through what the investigators found. So out of 145 randomized neonates, 142 were included in the intention to treat analysis, 73 in the control group, 69 in the intervention group. Severe ROP developed in 16 patients in the control arm, 14 in the intervention arm. So that's 28.6% versus 25%. The risk difference was negative 3% with a 95% confidence interval from minus 21% to plus 14%, and the p-value was not significant. When we're looking at ROP requiring treatment, it was observed in 13 controls and 12 in the intervention, 22% in the control, 21% in the intervention. Again, not significant. The composite outcome of death, severe ROP, BPD, and NEC was seen in 76% of the controls, 82% in the intervention arm, also not significantly different from one another. What's important, obviously, is how many how many protocol violations did they have? And that amounted to about like 42% of the cohort. So that's a lot. 24 patients in the intervention group received adult RBCs, contributing to the dilution of the intended intervention and complicating interpretation. So what's interesting is that if you look at how the trial was designed, an intention to treat analysis, and you look at the numbers, no statistically significant difference between the two. But now, if we start taking into account these protocol deviations and we start looking at two other ways, and we look at the per protocol analysis, this is where it gets interesting. Only 17 patients in the intervention group actually received only cord blood derived RBCs prior to 30 weeks postmenstrual age. They were compared to 38 patients in the control group who only received only adult RBCs. And when they're looking at that, severe ROP occurred in 34% of the control and 0% in the intervention group, which is obviously a very striking difference. When looking at ROP requiring treatment, it was seen in 26% of the control and 0% in the intervention group. And they even saw a reduction in BPD, 63% in the controls compared to 29% in the cord blood derived RBC group. When we're looking at an as-treated analysis, meaning we did 3 groups, you had 49 patients who received only adult RBCs. Then you had 17 babies who received only cord blood RBCs. And then you had 15 who received both in this particular, with no particular cutoff in terms of when they received it. In this analysis, severe ROP occurred in 36% of the babies who received adult RBCs, 0% in the ones who only received cord blood, and 53% in the mixed group. And there were similar results for ROP requiring treatment. Even after adjusting for confounders like gestational age, birth weight, sex, intrauterine growth restriction, ABGAR scores, etc., adult PRBC transfusions given before 30 weeks significantly predicted both severe and treatment requiring ROP. And so the conclusion of the authors was that the BORN trial is the first in their assessment prospective randomized control trial evaluating the clinical impact of cord blood derived RBC transfusion. And the trial results suggest a significant favorable effect of cord blood RBCs in preventing and or minimizing severe forms of ROP and BPD, and indicate the urgent need for larger randomized studies. And obviously, this is where we see that the trial design is becoming a bit of an issue, because in the intention to treat, they cannot really make a formal conclusion. But it's these other analyses, the per protocol analysis, the as treated analysis, that maybe shine a light on an avenue where if we were rigorously following the intervention, is there a signal there? And I think that this was quite interesting.
Yeah, I think it's really, innovative, exciting. I think when we think about those like innate stem cell potential, like it's like the door's wide open potentially on how we could use some of these. I mean, obviously, we had to do the studies, we had to see if it works, but it feels like there's like all this untapped potential.
Yeah.
Yeah, very
Yeah. Very
interesting.
cool.
Thanks, buddy.
Yeah.
Okay, I had this paper that I think will spark some interest. This is in JAMA Pediatrics. It's outcomes of preterm infants born at 22 to 23 weeks gestation in 11 international neonatal networks. And I will underscore that none of those international networks are in the United States. So I think we're going to get a really good picture of what's happening around the world. So this is from the International Network for Evaluation of Outcomes Investigators, the EBNeo investigators, who are looking at exactly that for these very small, very early babies. What does it look like across countries? It'd be nice if they included us. But these countries also have better national registries, obviously. Like, we have a lot of networks that collect data, but we don't have a national registry. So I'll get into it. Their question, their objective was really to evaluate survival and major morbidities, and what does the variation look like across these national networks for infants born at 22 to 23 weeks gestation. So basically, what they did, they took a anonymized Am I saying that right? Anonymized
Anonymized, yeah.
patient level data on neonates born before 32 weeks gestation. So that's what the EBNeo database collects. Or so born before 32 weeks gestation or with a birth weight less than 1,500 grams. And the NICUs were in these following neonatal networks. So Australia, New Zealand, Brazilian, Canadian, Finnish, Israeli, the neonatal network of Japan, Spanish, Swedish, Swiss, Tuscany, and the UK Neonatal Collaborative. But they were trying to highlight specifically this subcohort of the 22 to 23 weekers. They actually, I think, did a very nice job of really trying to verify gestational age. So they used the best estimate in this order. So if you had an in vitro fertilization date, an early prenatal ultrasound, which they indicated that they had for greater than 90% of neonates, last menstrual period, or the physical exam at birth, and in that hierarchical order. So if they had the IVF date, then that was the date that was selected. They looked at maternal corticosteroids. Any administration of corticosteroids was considered receipt. So obviously they had different protocols. One dose would be counted as receipt of antenatal steroids, where, say, here in the States, we would want to see, 2 doses. They looked at a number of pregnancy-related comorbidities and then a lot of neonatal comorbidities. But the primary outcome was survival to NICU discharge, and the secondary outcomes included grade 3 or 4 IVH. They also wanted to look at PVL, ROP that was treated either by ablation or anti-VEGF injection. They looked at BPD, defined as oxygen use at 36 weeks postmenstrual age or at the time of discharge, if earlier than 36 weeks. They looked at neck, Bell stage 2 or higher, survival without severe PDH or PDL, and survival without severe PDH, PDL, or ROP receiving treatment. They highlighted that they didn't include NEC and BPD in that composite outcome due to concerns about the kind of between network variability of those diagnoses. So, the overall cohort included 5,019 infants. Of the 5,019 infants, 17% were born at 22 weeks. That was 846 babies. And 4,173 or 83% were born at 23 weeks gestation. And then they really wanted to look at the variation. So number of infants admitted for neonatal intensive care in each network there was a wide range. So at 22 weeks, it was from 0 infants in Switzerland to 404 infants in Japan. And then for 23 weeks, the lowest was 37 infants in the Italian cohort to 1,097 infants in Japan. And I'm realizing I didn't tell you the dates. They were using, the dates from 2015 to 2021. So, for as far as a decade ago. Okay. Then they wanted to look at each of some of these following characteristics. So, for example, for antenatal steroids, they receipt of antenatal steroids went from 18% all the way to 83% in the 22 weekers, depending on the national cohort, 57 to 98% compliance in the 23 weekers. And they looked at C-section births, 0 to 42% in the 22 weekers, and 5 to 73% in the 23 weekers. And then they wanted, like I told you, to look at survival to discharge. There was also significant variation there. So in infants born at 22 weeks, the survival to discharge was between 9% and kind of the lowest performing unit up to 64% in the highest performing unit network. And then in the 23 weekers, 16% to 80%. So a lot of variability there. Severe PVH or PVL, 24 to 65% across networks in the 22 weeker and 18 to 56% in the 23 weeker. Survival without severe PVH or PVL, 7% to 53% in the 22 weeker and 9% to 69% in the 23 weeker. ROP receiving treatment among survivors, 32 to 57% in the 22-weeker and 16% to 48% in the 23-weekers. Survival to discharge increased day by day of gestational age and substantially differed between early and late parts of the week within the same gestational week strata. So, I mean, I think we know that. We see that at 22 and 0 tend to have worse outcomes than the 22 and 5, 6 weeks
Yeah.
babies. So when we tell parents that every single day matters, that really uh, is shown here. Then they looked at these different epochs. So survival to discharge was not significantly different between 2015 to 2017 and the 2018 to 2020 for any network except for the Swiss neonatal network, which did show a significant increase in survival at 23 weeks in the later time period. And then they have these nice graphs that really kind of show you by neonatal network, obviously looking at the each day of life between 22 and 0 and 23 and 6. And for all of the networks, there's this kind of upward slope, linear correlation. You can see some of the networks, really were not admitting anybody in the 22 weeks.
Yeah, the graph begins a little bit later in
That's
in
right, for those
the gestation.
groups. That's right. And then I wanted to show the adjusted incidences of survival major morbidities in infants born at 22 weeks. So, I mean, the top performer, let's say, of survival to discharge is definitely the Japanese network, with it looks like about 65% survival to discharge. And they have the lowest adjusted probability of severe PVH or PVL, about 25%, and their survival without severe PVH or PVL is the highest of all the networks. I'd say about 55% of babies in the 22 weeks survival without severe PVH or PVL. They have low rates of neck. I mean, consistent with, I think, reports around the US, about 7%. And they do still have quite a bit of ROP requiring treatment. About 55% of babies had ROP requiring treatment. And those trends are pretty similar in the whole cohort, 22 to 23 weeks.
Yeah, but I think
Go ahead.
no, but I think it's where it gets really interesting to dissect the numbers on in this particular paper, because let's talk about the Japanese, for example, and I'm only using them because they probably have established themselves as one of the countries of excellence when it comes to the care of these babies. And it's important to realize that their outcomes for babies born at 22 weeks and babies born at like 23 and 6 are not the same. Like they're not, like there's still a big difference. And when you look at this graph and you try to isolate the Japanese, and it's kind of easy because they're sort of floating above everybody else. So it's kind of nice to see that trend. But a 22-weeker in Japan has a percent chance of survival of about 40%. And if you're 23
The
and
22
5,
and 0, right?
22
Yeah.
and 0. But if the same baby is born at 23 and 5, then the odds are like 80 some plus
Mm-hmm.
percent. And
Yeah.
so there is still they haven't solved this particular
No.
problem, and that trend continues to manifest itself of, yeah, the odds are going to be the lowest at the lowest gestational age,
Mm-hmm.
even in Japan. Like,
Yeah.
and 40% survival means 60% mortality, um and that's a big deal. That's a big
Yeah.
deal. So I think
Agreed.
that it
In And it's not just that they've established themselves as a country of excellence, but they've been doing it for longer than
yeah,
most other
they've
countries,
established
right?
themselves from the standpoint of their numbers are just some of the best in the
That's right.
world.
That's
Yeah.
right. Yeah,
And they've done
absolutely.
because they've done it for much longer.
Longer. Yeah. So I thought this was interesting as we keep seeing papers about what are our US outcomes, how do we what are we doing and what are our international colleagues doing? I think it's really interesting.
Yeah. And I think it puts perspective on those prenatal consults.
Mhm.
Um, and yeah, it's quite interesting, especially when I mean, we've been dealing with a lot of pre-viable sort of consults where we have to cancel what will we be doing at 22 weeks and so on. It's just it puts everything in perspective for sure. Okay,
Absolutely.
maybe we're going to take a very quick break, and then when we come back, we will have our EBNeo segment for this month. So see you in a little bit. So we are joined today for this EBNeo segment by one of the Incubator team members and host of the French edition of the Incubator podcast, Dr. Gabriel Altit. Gabriel, welcome to the podcast.
Thank you so much, Ben.
For people
It's
who
such a
don't know,
pleasure to be here.
Yeah, it's a pleasure to have you. I mean, and for the people who don't know, you were interviewed during the Neo Hard coverage of 2023.
3? Yeah, I think so.
23.
That's a
And
long
that's where it
time
all
ago.
began. So it's cool that to have you back. And if people need to hear more of Gabriel, there's so many outlets. He is the host of the French edition of the podcast, but definitely check out his main site, neocardiolab.com.
Thanks, Ben.
You're
So
welcome.
it's a bit weird to be on this platform and actually speaking English. I'll be fully honest. I feel like
We literally just recorded a French podcast, so it's asking us to switch languages on the fly, but we're going to do it. So today, Gabriel, you're coming to talk to us about an article that we reviewed on the podcast that was published, I believe, in the Journal of Pediatrics called Norepinephrine versus Dopamine for Septic Shock in Neonatal, a randomized controlled trial. We were able to review that study on a previous episode of the podcast, but for those of us who may not remember exactly what they were looking at between norepi and dopa, can you summarize for us what was the question, how did they study it, and what was the main findings?
Yeah, absolutely. So, again, this paper was published in Journal of Pediatrics. It was a randomized controlled trial. Basically, they compared 80 neonates with what they called fluid refractory septic shock. They either allocated norepinephrine in 41 of them or dopamine in 39 of them as the first choice for the first-line therapy. And well, they have a whole algorithm in order for escalation, and obviously everything was blinded, so they had to make sure concentrations were appropriate to achieve these various targets for the dosages. The primary outcome for the study was actually what they called shock reversal at 30 minutes of the initiation of the vasoactive drug. But they also looked at, many other outcomes, mortality. They looked at NIRS profiles. They look at acid-base balance, lactates, and some of the side effects potentially of the drugs like glycemia, tachycardia, and some of the other common morbidities of infant septic shock. What they call the primary outcome, which is shock reversal within 30 minutes, was partially related to some of the parameters that we commonly measure in the NICU for some of these patients, but also a lot of it was related to actually physical exam endpoints, so like capillary refill, normal pulses, and things like that. So not just about a blood pressure or lactate or other such things. What else? So that's pretty much for the methodology that they used as a brief summary, because I know you already discussed this particular article on the English edition. In terms of the outcomes of the study, what did they find? They find that basically their primary outcome of reversal of shock was quite similar between both groups. So we talk here about 32% and 46%. And they looked also at the need for second agent or third agent, which was quite similar between the two groups as well as the requirement for steroids. So there was not much differences in much of the primary or secondary outcomes that they were measuring for this particular study in this population. But they did have in their table 3 a few of these other markers that they looked at. So one of them was, for example, the use of NIRS, which they looked for the first 24 hours after the initiation of the intervention. And they found that at 24 hours, the cerebral NIRS had higher values in the group that was exposed to norepinephrine. And they also found that patients exposed to norepi had slightly better markers of acidosis. So the pH at 6 hours was the pH, is it at 6 hours? No, so at 24 hours was 727 in the norepi group as an average compared to 719. And there was slightly different CO2s as well during that timeline. So not huge differences between the two groups, but maybe some elements and their secondary outcomes that would favor the exposure to norepinephrine in this small study in terms of population. And just to mention also, it was a study that was done in one single center, level 3 NICU in India. And they also provide some of the profile of the organisms that they had in terms of culture whenever they had a positive culture, because it's important to mention that they had quite a significant portion of their population which was with negative cultures, but with what they call this positive screen with inflammatory markers. And so if we're looking at particularly some of the organisms, we see that the majority are Klebsiella, but they had quite a significant amount of Acinetobacter. I wouldn't be able to tell this with an English accent. But they also had like some E. coli, Pseudomonas, MRSA, and MR cons, but like no bacteria like GBS, for example. They also had quite a diverse population in terms of gestational age and birth weight. So although their average is 33 weeks for both groups, we can see that they had kind of babies spanning the less than 35 weeks to the more than 35 weeks. But when you look at the birth weight, we can see 1.6 kilos the average. So not that many patients that would be kind of less than 1,000 grams or less than 28 weeks or extreme preterm range based on the data that they provide. So that's kind of the summary, big picture of the study. Their conclusion is that obviously we need more trials and more studies to kind of understand what's the best agent to provide during episodes of shock. But that from their preliminary or at least initial data that they obtained in this particular study, norepi seems to be as well tolerated as dopamine, and seems to be conferring maybe better profiles in terms of metabolic acidosis and NIRS values once shock has initiated in their particular population.
Yeah, I think this was obviously a very interesting article, and I think that the population you did a good job at sort of breaking down that type of population and obviously the incidence of sepsis. And what's interesting is that dopamine and norepinephrine are very similar in terms of their profile, in terms of some of the receptors on which they act, and they are related to one another, but they're not exactly the same. And so I am wondering a little bit in terms of what you wrote in your commentary about what do you think methodologically about using this comparison in this particular population, and also the team being quite astute in not just looking at blood pressure as a number, and looking at other measures of blood pressure like near infrared spectroscopy.
Yeah, no, totally. Well, first of all, I'm going to say that, in general, doing trials in this group of population that are quite sick is always commendable in the sense that, as you know, it's very difficult and challenging to recruit these patients. They may come at any day and time of the night. They're quite sick. Parents are very worried. And so just the simple fact of attempting to do a trial like this is already something quite commendable for this team. So I want to outline this. I think to answer your question about the methodology itself in terms of using all of these other markers of perfusion, I mean, it's interesting and provides great information, especially for those who are looking and designing like a follow-up to this study and maybe expanding this to a bigger population in order to understand it, individually, what are these agents doing in particular subgroup. I think one of the concern or the challenges with this study is that it has like a whole bag of different gestational ages, birth weights, etiologies. And so can you necessarily then generalize the conclusion to like subgroups within this population? It becomes a bit more challenging, especially if you're looking at extreme preterm patients who develop bacteremias and secondary sepsis and secondary shock. Um, this study may not necessarily represent fully that particular population, which is often one of the highest risk that we see in our NICUs. So that's one thing that comes to my mind. The other thing is that when you look at the primary outcome, shock reversal within 30 minutes, you could argue that, of course, when you look at surviving sepsis campaign and all of these other hallmark articles, looking at trying to improve mortality with this very severe condition, you want to reverse this shock picture as early as possible. But I think that as an outcome, it is also important to look at some of these other elements like mortality from the shock episode, which may require a much bigger sample size in order to kind of show a difference between different types of agents. And the other difficulty that sometimes we face in the clinical grounds is that, different babies may present very differently and their response to the inflammatory surge may be quite different. We may have babies or patients that will present a significant vasodilatory type of shock. Others may have a lot of cardiogenic features to their shock. And so um, a one recipe fit all may be difficult to apply. And so I wonder if future studies should actually look into algorithms based randomized control trials or adaptive randomized control trials where we're able to actually incorporate strategies based on much more physiological information. For example, if you have a patient with severe cardiac dysfunction from an E. coli sepsis, maybe just putting norepinephrine may not be the solution in that particular baby, right? Because you're going to increase significantly afterload and you're going to increase a lot the SVR. And while it will be a drug that has a lot of interest in a vasodilatory shock, it may not be the solution for some of these other babies that have very complex hemodynamics in that particular neonatal septic shock episode. So I think kudos to these authors to attempt to, find an answer to what's the best strategy in what they call septic shock to get this outcome of shock reversal. But for me, I think I would want to see, mortality outcomes that are different. I would want to understand better how these drugs are impacting the different phenotypes based on, this multimodal assessment that you were mentioning.
Yeah, I think that's exactly right. I think that you could look at it from the standpoint of um, identifying the merits of each of these medications, or you could look at it from if you do not have a sophisticated and robust hemodynamics program, where, like you said, you could actually look at the hemodynamics and the effect on the myocardium in terms of what does that change being on norepi versus on dopamine in this particular patient. Because again, like you said, they might need to be looked at individually. Then it's also
Hmm.
interesting to know that it's not like one is dramatically better than the other. And so it's interesting. And to me, what's always funny is that the adults know this, know that in sepsis, norepi is quite good. So it's just confirming something that many of our colleagues also know, that we could use norepi in septic shock. And I think that the setting is also very important, as you mentioned. I think that the fact that this was done in India, I think, is also an interesting point, because for many of us, even in the US, like the resources are different. It's
Hmm.
very variable, at least from one place to the next, up the street, down the street, not even necessarily from state to state. So I think that's very interesting. Um, and do you think? I mean, you're very biased, obviously, but do you think that you mentioned how difficult these studies are to be done, but does that mean that moving forward, if you don't have hemodynamics to assess the response, you just can't do these?
I no, I mean, trials are going to be and are going to stay the gold standard to better understand what are the best strategies. I just wonder if, practitioners and scientific who are doing hemodynamics and those who are designing effective trials, should sit down together and better understand how can we in a trial setting incorporate all of this, whether it is algorithms that you compare within a trial model with some of these outcomes that are both hemodynamics related, like blood pressure and perfusion, et cetera, and some of these important parent related outcomes. I think that's going to be where precision medicine can be better tested. So I think we just need to sit around the table and how to think this through. The problem is that these studies will probably require a lot of collaboration among sites, a lot of patient population, and as we outlined earlier in this discussion, these are patients that are very difficult to recruit. Um, I'm even amazed of how they were able in this particular study to recruit these septic shock patients that were very sick from the get-go and that had quite some degree of high mortality. So, and it's actually unclear, and I do mention in the commentary, it's unclear to me how they obtained consent. Was it like deferred consent? Was it like prospective consent? And so, when you establish these kinds of trials, you really need to think through how you're going to be able to kind of take all of these boxes and make sure that you're consenting appropriately, informing appropriately the families when they're kind of living very challenging moments. We're currently So two things I wanted to mention out of what you said. So we had like a PS platform 2 years ago in Toronto, actually, with Audrey Hibbert, Stephanie Ford, Satya, and Shazia, and we decided to put together an article out of this platform, and it includes a lot of information relative to the fact that the status quo about using just a dopamine centric approach is probably something we need to start to challenge as a practice, and how, although we don't have as much trial data, we do have a lot of cumulative data that there are agents that are leading to different effects to our babies. And so this particular trial that we just reviewed today, I think, will add on to the body of information that, as you said, an agent like norepi is definitely usable and seems to at least be equivalent. And there may be some elements that shows a bit of improvement in some of these soft markers of perfusion, but that we need much more studies, right? And that we need to better understand how much of these different agents can be used to tailor the treatment, but that they're all at the end toxic, right? So we have to be aware of that. We have to be aware of, the polypharmacy. We have to be aware that different gestational ages may not necessarily respond the same way, the immaturity of organs. And so we have to be very cautious as we advance as a community, using the best information that we have to tailor the treatments. And hopefully there'll be more of these trials that are like kind of spanning from this to better understand, well, is norepi the best agent? Maybe it's epi, maybe it's a combination, maybe it's a titration, maybe it's to, include various monitoring tools to kind of tailor the therapy, get rid of it as quickly as possible when it's not necessary anymore. But I think that this first study is definitely kind of a good one to start thinking about how to design trials within our context, for example, in our NICUs in North America and Europe, and how can we apply these ideas to design trials, including hemodynamics principles, so that we can finally answer some of these questions about what's the best agent, the timing, the dose, based on the different context and the different gestational age and maturity level. But yeah, more questions than answers, I feel.
As always, Gabriel, we thank you for taking the time to share your commentary, and we'll speak to you very soon on the Incubator.
Thanks for having me here. It's always a pleasure. And I didn't even speak French, so bonjour à tous.
You can wave off. You can sign off in French if you want.
Parfait, super. Alors, je vous souhaite une belle journée à tous. Have a nice day, everyone.
Merci. Okay, we are back. Thank you for the EBNeo team for contributing to monthly journal clubs. I want to take us next to another article that was published in JAMA Peds Daphna, following up on your latest review. And this is a paper called Respiratory Targets Associated with Lung Aeration During Delivery Room Resuscitation of Preterm Neonates. I found this to be a very interesting article. I'm going to tell you who is the first author. It's David Rube. Senior author is Liz Foglia. Haresh Kirpalani is on that paper as well. And what's interesting is that this is a paper that addresses the transition from intrauterine to extrauterine life, and the fact that it requires really rapid and effective lung aeration, particularly when we're talking about preemies whose lung structure, physiology, functionality, obviously, due to that immaturity, makes it more complicated. So we know from resuscitation, from NRP, from LCOR, that positive pressure ventilation is what's needed for these infants, and that it matters tremendously how well you deliver PPV. It also is a very risky procedure because these infants are at high risk of barotrauma, volute trauma, and in the delivery room, depending on what you're using, um, you may be inadvertently delivering too much pressure. So it's always a fine balance, and there's been a lot of papers that have come out on how good are we at delivering what we intend to deliver in the delivery room. Now, the current guidelines, like the ones from the neonatal neonatal resuscitation program, suggest to start PPV at a peak pressure of 20 centimeters of water. But what is not really yet known is what is the tidal volume and pressure that actually lead to successful lung aeration in the real world. And we assume that by giving 20 of pressure of PIP, then we are actually delivering the right tidal volume, but we don't know. And so this is the study that they coined the INFLATE study, that aimed to prospectively identify respiratory parameters such as pressure and volume that are associated with successful lung aeration using the most reliable clinical signs we have, which is getting a sustained heart rate above 100 beats per minute during delivery. So this was a prospective multi-center observational cohort study conducted under the umbrella of the INFLATE initiative, short for infant lung aeration during transition events. And this is a study that's coordinated at UPenn and Children's Hospital of Philadelphia. So basically, the data came from two sources. They had an observational cohort of eligible preterm infants born between 2016 and 2021 at the hospital of the University of Pennsylvania, and then they had another cohort that they had from the SAIL trial, the Sustained Aeration of Infants Lung trial, which we reviewed in the past. It's an international randomized control trial comparing sustained inflation to standard PPV. Now, what they are looking at is basically using what's known as RFM data, which basically helps give you lots of different measurements on respiratory parameters. The babies that they included in the study were babies born between 22 and 31 weeks of gestation, and they had to receive positive pressure ventilation for bradycardia after birth, which was a heart rate being below 100 beats per minute. And they had to have this RFM, this respiratory function monitoring data, available during the resuscitation. Babies that had major congenital anomalies, pulmonary hypoplasia, and so on were excluded. The outcomes they were looking at were the sustained increase in heart rate above 100 beats per minute, lasting for at the very least 15 seconds. And this was used as a surrogate of successful lung aeration. Each neonate was followed from the first positive pressure ventilation inflation until either their heart rate increased to 100 beats per minute or 10 minutes had elapsed. And if neither occurred within 10 minutes, then the case was censored and classified as target not reached. So in terms of the respiratory function monitoring, this basically gives you information on your PIP, on your inspiratory tidal volume, on your expiratory tidal volume, on your leak from the mask, on the number of spontaneous breath, and also informs you on number of masks removal. So these metrics are captured continuously, giving them basically some real-time insights into what is happening during each breath. Now, there's something very interesting about the statistics of this paper. I know I'm sort of geeking out on statistics this month, but they used something called a penalized spline, which is something that I was not super familiar. I was familiar with the concept. I didn't know what this was. But basically, the penalized spline is basically a way to model the association between continuous respiratory measures, like, for example, the expiratory tidal volume, and the probability of achieving your primary outcome. So what is it? What is penalized spline? So think of it this way. If you're trying to understand how one continuous variable, like your tidal volume, affects an outcome, like your heart rate, you could draw a straight line through the data. But what if the relationship isn't exactly linear? Then that's where splines come in. And basically, this allows for curves. So a penalized spline is a flexible statistical model that lets you fit a curve to the data, but penalizes the model for becoming sort of too wiggly or for performing too much overfitting. So the line is allowed to bend a little, but not to go completely crazy. And I think that this is very useful because when you suspect that there's a relationship between your variable and it's not strictly linear, what we tend to do as researchers is to say, well, I'm going to establish an arbitrary cutoff. And that's when you transform a continuous variable into a categorical variable. And that has a lot of inherent issues. So in order to avoid doing that, you could use this model of penalized splines, which allow you to continue to use your variable as continuous, but allow some curving of that relationship even when it's not completely linear. So the primary data set included 132 infants. 113 came from the observational cohort. 19 came from the SAIL trial. The median gestational age at birth was 26.6 weeks. Roughly half of the babies were male. The median mask leak was about 30%, which with an interquartile range, ranging from 0 to 68%. So we are still victims of that goddamn mask leak. We're still not that great about that. So out of these infants, 125, 94% achieved a sustained heart rate above 100. The median time to reach that target was about 116 seconds, just under 2 minutes. So what were some of the associations they noted with the heart rate increase? So in the unadjusted model, participation in the SAIL trial was associated with an increased likelihood of heart rate improvement, but this association disappeared when the model was adjusted. So among all clinical covariates, birth weight was the one significant variable associated with a heart rate improvement. For every 100-gram increase in birth weight, the adjusted hazard ratio was 1.12, which is not really surprising that bigger babies will be more likely to reach a good heart rate. When we come to respiratory parameters, that's really what we were interested in. Only expiratory tidal volume was positively associated with an increase in heart rate with an adjusted hazard ratio of 1.1. When in contrast, the PIP and the inspiratory tidal volume showed no significant association with the primary outcome. Also, and not surprising, increasing the number of mask removals was associated with a lower likelihood of heart rate improvement. So don't continuously take out that mask to do whatever. So let's explore tidal volume and use the penalized splines method. So the authors found that the relationship between expiratory tidal volume and heart rate wasn't exactly linear, and there was a clear benefit at some lower expiratory tidal volumes, but it sort of leveled off beyond a point, which were not really surprising. And so what they found was that consistent expiratory tidal volumes reaching up to 4 ml per kilo was strongly associated with an increased heart rate. But beyond 4 ml per kilo, the effect plateaued. And a similar pattern held true with 5 ml per kilo threshold. So it's interesting that we know, for example, so it seems that achieving a minimum of 4 to 5 ml per kilo may be enough to trigger successful lung aeration in preterm neonates, but that going beyond that volume didn't really yield at least further benefits in terms of heart rate for that particular cohort. We know that the tidal volume expectation is 4 to 6, and a lot of people always ask, like, how do we know that? Where do we get that number? But it seems like it's holding true with this particular data set. When they used the confirmatory data set in the second data set of 115 infants used for confirmation, this group also showed that an expiratory tidal volume of about 4 ml per kilo was beneficial. So the conclusions are that in this particular population, and confirmed in another, a minimum expiratory tidal volume was associated with successful lung aeration during preterm neonate resuscitation. Further clinical trials are needed to establish the utility of volume-targeted resuscitation in preterm neonates. I think that this is something that should start being integrated directly into our resuscitation tables, if you ask me, because it seems that that particular piece of information could really help us perform better resuscitation in the delivery room. So I thought that was very interesting.
Yeah, I agree. That kind of like in real time feedback, I think, will be very
Yeah.
valuable for sure. For sure. Very neat. Okay.
But that
Well,
it's
go ahead.
real-time feedback, but also the fact that it's the expiratory tidal volume you're
Yeah,
getting
right.
that matters most. And so you have, like, how much leakage you have around your mask matters tremendously.
For
And
sure.
it is what the baby can send back that really informs you on how well and it's probably a much more granular way of looking at this rather than saying, oh, do I have symmetric chest rise, for
Mhm.
example. Like that's a very
The
crude
bare
way,
minimum.
comparing.
Yeah. Very cool. Well, since you were highlighting bradycardia, I'll carry that vein along. We've got an article from the Journal of Pediatrics. It's atropine versus placebo for neonatal non-immersion intubation, a randomized clinical trial. Lead author Jahir Fifi, senior author, our good friend Michael Narvi. So they wanted to compare the rates of severe bradycardia, so less than 80 beats per minute for greater than 10 seconds, between neonates who received the combination of basically RSI, so atropine, fentanyl, succinylcholine. So this was the atropine group versus placebo, fentanyl, succinylcholine before orotracheal intubation. So, I mean, the background, they really talk a little bit about how, rapid sequence, induction is kind of the standard,
Intubation.
but say that
Rapid sequence intubation,
yes. What did I
not
say?
induction.
Induction. No. Just finished talking to our L&D colleagues. Rapid sequence intubation. So, but that they've done polls, right? And basically, very few neonatologists or NICUs in general have a pre-medication protocol. Some people use it sometimes, but not all the times. And, more than 10% of units weren't using any pre-medication for non-emergent intubation. So they wanted to look at that specifically. Okay. So basically, it was a multi-center, double-blind, randomized clinical trial in 3 academic units in Canada. And eligible neonates were admitted to the NICU at these sites. They had a postmenstrual age of less than or equal to 44 weeks and were expected to receive a non-emergent. So basically, within 30 minutes from decision for intubation, maybe for surfactant or some sort of elective intubation, like for a procedure. They excluded infants with cyanotic heart disease, upper airway anomalies, anybody who needed an urgent intubation, and those with any contraindications to the medications given, specifically succinylcholine. So it looks like every week they pre-prepared these masked vials of study medication. So either, I mean, all the meds, but either atropine or placebo. And then at the time of needing intubation, consent was obtained, and then the babies were randomized. So then the baby either got the placebo vial or the atropine vial. And then all the infants also got pre-medication with fentanyl and succinylcholine. They also got pre-oxygenation, so ensuring that they had an oxygen saturation of 90% before intubation. All the intubations were orotracheal. They used direct laryngoscopy, and they said, quote, limited to the most experienced intubator in attendance. And then importantly, when they wanted to document intubation attempts, so anytime that the laryngoscope blade was put in the mouth and taken out, that was an attempt, whether or not somebody introduced an endotracheal tube. Intubation was interrupted if there were 30 seconds of bradycardia, less than 100 beats per minute. And they had somebody at each intubation session manually recording the time of each intubation attempt. And they also were tracking a number of vital signs, obviously heart rate and saturation. That's really what they were looking at. But they also looked at blood pressure, checked at 2 time points: 10 minutes before study medication and 30 minutes after the completion of the intubation. The primary outcome was looking at severe bradycardia, like I told you, so a heart rate of less than 80 beats per minute lasting for greater than 10 seconds during the whole procedure. The secondary outcomes they looked at were intubation conditions. So they wanted to look at the number and the duration of temps and the total intubation and procedure times. They wanted to look at other physiologic responses. So overall bradycardia, any heart rate of less than 100 beats per minute for greater than 10 seconds. Episodes of hypoxemia, so SATs less than 80% for greater than 10 seconds. The duration of severe bradycardia, were they associated with hypoxemia? Were there episodes of tachycardia, so heart rate of greater than 200 beats per minute for greater than 10 seconds? The mean and lowest heart rates in SATs, and the pre and post changes in heart rates in SATs, and as I mentioned, the blood pressure. They also looked at safety outcomes, so profound bradycardia. So I told you they were specifically looking at less than 80 beats per minute, but profound bradycardia they defined as heart rate of less than 60 beats per minute for greater than 10 seconds. And the receipt of advanced resuscitation, so needing chest compressions or epinephrine. So these were predefined kind of stopping rules. Okay.
Mm-hmm.
So now we can get into it. They screened 305 neonates and who were eligible, but in total they had 60 neonates. Some neonates had more than one participation, so 76 intubation events who were randomized. So neonates had a mean gestational age of 29 plus or minus 4.6 weeks, a mean birth weight of 1,466 grams plus or minus about 900 grams. 31% were less than 1,000 grams at the time of intubation. There was no difference between the groups. So 33% in the atropine group were less than 1,000 grams, and 31% in the placebo group were less than 1,000 grams. They had a total of, I told you, 76 intubation events, but some didn't have all the information necessary for the primary outcomes. So they used these 73 intubation events. 49 were among those who received placebo, and 24 among those who received atropine. So of 24 of the total intubation events out of the 73, so that's 33%, were multiple attempts. And this was statistically significant between the two groups. Actually, the placebo group was 26% requiring multiple attempts. The atropine group, 46% requiring multiple attempts. 11 events had repeated need for additional succinylcholine, 18% in the placebo group and 8% in the atropine group, but this was not statistically significant. Across the board, the indications for intubation were RDS, 26%, surfactant administration, 23%, procedures, 22%, unplanned or failed extubation, or an unplanned extubation, accidental extubation, 16%, and apneas, 12%. So regardless of the randomization arm, none of the procedures was complicated by that profound bradycardia less than 60 or needing advanced resuscitation procedures during the study period. Thank goodness. So for their primary outcome, looking at severe bradycardia of less than 80 beats per minute for greater than 10 seconds during the whole procedure, was actually 6 times higher in the placebo group compared with the atropine group. So 25% in the placebo group had that severe bradycardia versus 4% in the atropine group. The placebo group also showed significantly longer duration of severe bradycardia and higher rates of severe bradycardia, 43% in the placebo group, 12% in the atropine group. The median duration of overall bradycardia was also different, 10 seconds in the placebo group versus 0 seconds in the atropine group. Associated hypoxemia was seen in 59% of the placebo group versus 87% in the atropine group, so higher in the atropine group of the associated hypoxemia, and this was statistically significant. In addition, the median duration of the hypoxemia, 9 seconds versus 38 seconds, was also statistically significant and was higher in the atropine group. The study groups, though, were not totally equivalent when it came to the number and duration of, which is interesting. So compared with the placebo group, the atropine group actually had a longer median time to successful intubation, 394 seconds in the atropine group versus 282 seconds in the placebo group. This was statistically significant with a relatively greater proportion of multiple intubation attempts and lower rates of first successful intubation. So 54% in the atropine group versus 73% in the placebo group. So this was statistically significant. So to kind of reiterate that to wrap it up, they needed more intubations attempts, longer time to intubation in the atropine group. They had longer hypoxemia episodes, but they had much lower rates and length of time spent in the severe bradycardia. They looked at the other vital signs. There was no difference in baseline measurements between the study groups 1 minute before the procedure. During the procedure, the placebo group had significantly lower mean heart rate, 147 beats per minute versus 159 beats per minute. The placebo group had a median lowest heart rate, 83 beats per minute versus 136 in the atropine group. And there was greater heart rate variability with a 20% change from baseline in the placebo group, 84% versus 58% in the atropine group. There were no differences in blood pressure. There were also no differences in the primary outcome, though there were differences overall in the primary outcome, less severe bradycardia in the atropine group. There was no difference in the primary outcome between the study groups during the first intubation attempts. There were no instances of the severe bradycardia in the atropine arm. The placebo group did experience this outcome. So 0% in the atropine arm, 10% in the placebo group. Placebo use led to significant lower mean heart rate, a lower median lowest heart rate, and longer median duration of overall bradycardia compared with atropine use. But the median lowest saturation was significantly higher in the placebo group compared with the atropine group. So again, to reiterate, there was a 20% absolute reduction in the rates of severe bradycardia, so less than 80 beats per minute for greater than 10 seconds, favoring the atropine arm. But compared with the placebo group, the atropine group had significantly lower rates and durations of overall and severe bradycardia, but higher rates and durations of associated hypoxemia compared with the placebo group, which was likely related to the greater proportion of multiple attempts and longer time to successful intubation. So I guess my takeaway is it depends what the problem is in your unit. if, if bradycardia is really a big problem in your unit, then considering atropine. Um, they couldn't really quite explain why the babies needed more attempts or longer total time, which
Yeah, I
are
mean,
not benign.
I think some intubations are harder than others,
Sure,
just based on anatomy and
absolutely.
other parameters. And I think that the the heuristics that I'm sometimes fall prey to, which is like, oh, this I'll be able to intubate
Yeah,
very quickly.
right
I,
before
I
sign
don't
out.
I don't need to premedicate as much. I think
Mm,
that's wrong.
yeah,
I think that it's interesting to see that yeah, I mean, you probably need to premedicate these babies so that you can buy yourself a little bit of flexibility, but it doesn't mean that you should take your sweet time either. I think you still need to be
right.
very fast even
Sure.
when they are premedicated, and that the measure of heart rate in and of itself is a good one, but it's not the only one. And I think that the overall stability of the patient is what you should look at, not
Hmm.
just say, oh, sats are 12 but the heart rate is okay. Like, that's not how it
That's right.
works. So uh, I think that what this paper, in my opinion, highlights quite well, because then we can get into you've done a good
Mhm.
job in getting into the nitty-gritty of the different outcomes and variables. But you should aim for a controlled, stable environment. And then what happens after that is beyond your control probably, but at least the things that are in your control should be controlled.
Yeah. No, absolutely.
And
And again, the placebo arm still had pre-medication, right? They weren't
that's
they didn't
right. That's
even
exactly
I
what I
think
was going to
Dr.
say.
Narvi doesn't even think it's ethical to do a totally a
Yeah.
non-medicated intubation. So,
Yeah. Fentanyl and succinyl choline.
yeah. Yeah.
So who knows? And sometimes I'm sorry to say, like, depending on how your medications are stocked, you say, "Oh, we just
Yeah.
have
If
fentanyl's
this is going
available
to
right
take an
now."
extra, 2
Yeah,
hours, then that's
yeah,
really problematic.
yeah.
Yeah.
And I've been in units where 30 minutes is not enough to get all that stuff set up and delivered. So um, Yeah, I mean, optimizing system-based practices is probably another interesting point. Um, yeah, it's a humbling. These
Oh,
papers are
it's a
always
good
humbling.
reminder. Yeah.
Yeah. Okay.
Because sometimes at the end of the intubation, you're just glad that it's over. And yeah, and sometimes if you're the intubator, you're not even really sure what all the vital signs look like during your intubation
Yeah, I mean,
attempt.
after the baby, especially if you're not pre-medicated and so on. Yeah, it's a very stressful procedure for sure. Okay. Do you have time for one more?
Yeah, do it.
All right, I'm going to do a quick one. It's a paper that was published in the Archives of Disease in Childhood, Fetal and Neonatal Edition. First author is Sam Gentle, and its paper is called Screening for Pulmonary Hypertension in Preterm Infants with Bronchopulmonary Dysplasia. When, how often, and does it matter? The title was very clever. I really liked it, so I dived into the
Yeah, how
article.
could you not read the article, you know?
Come on. Um, And I think that we are all aware that one of the major complications of bronchopulmonary dysplasia is the feared sort of BPD-PH phenotype, which is considered to be the most severe phenotype of BPD when you have associated pulmonary hypertension. And the question is, if the baby is not doing too bad, like when do I start screening for pulmonary hypertension? And there's some guidelines. I mean, the American Heart Association and the American Thoracic Society recommend a screening echo at about 36 weeks PMA. Um, but in specific cases, and these include babies who are on positive pressure ventilation, those you can't really wean from oxygen, or those whose oxygen need is kind of disproportionate to their pulmonary disease. Um, and so what is exactly the optimal timing and frequency? That is not really stated. Like, do we just do one? Like, do we do more than one? And so that's really what these authors are trying to answer. What is the best time to screen, and which strategy should we adopt to screen for BPD associated pulmonary hypertension? So this was a retrospective cohort study conducted at the University of Alabama between 2017 and 2023. They included babies who were born before 29 weeks of gestation and who required respiratory support at 36 weeks, and they had the usual exclusion criteria. But what's interesting and why the retrospective study actually works for this particular context is that they had a protocol where they do an initial echo at postnatal day 28 for babies who are on respiratory support. And then they do echoes monthly until discharge or until there's like resolution of their respiratory needs. So they use that protocol to basically see what they found. Um, a big question obviously is like, how do you define BPD associated pulmonary hypertension? And they said they were doing this based on these particular echocardiogram findings, either a bidirectional flow through a PDA or a PFO, septal flattening with an eccentricity index of 1.2 or above, or tricuspid regurgitation velocity above 2.5 meters per second. Again, is a bidirectional flow through a PFO sufficient to make a diagnosis of PH? I'm not going to get into that, but that's the criteria that they used. So they basically then took the data that they had and they looked at comparative screening strategies. And because every infant was screened systematically from postnatal day 28 until discharge, they retrospectively looked and compared. And they said, what about if we have an early screening, which is an echo starting on postnatal day 28 up until 36 weeks? What if we have a singular screening? We just try to do an echo around 36 weeks. What if we do late screening, meaning we start screening after 36 weeks until discharge? Or do we do a comprehensive screening where we look at all echoes from day 28 up until discharge? The early screening part looked at the same, but only until 36 weeks, just so that we're clear. Then they looked at true positives, meaning the first echo showing evidence of pulmonary hypertension, a true negative, where there's no evidence of PH during the entire hospitalization, or false negatives, which was based on misdetection during the earlier echoes, but then later finding that there is later findings of pulmonary hypertension during the hospitalization. So in terms of the results, they looked at 394 infants, 258 had BPD, 136 developed BPD-associated pulmonary hypertension. And for these babies, they had 2,542 echoes available for evaluation. That's a lot of echoes. In terms of patient characteristics, the babies who had BPD-associated pulmonary hypertension were not really surprisingly born earlier, with an average gestational age that was 24 weeks compared to 26 weeks in the babies who only developed BPD. They had a lower birth weight as well, and they were more frequent. more frequently treated with inhaled nitric oxide, more often treated with steroids, and more often had a PDA. Looking at the different screening strategies, the comprehensive screening detected obviously all 136 cases of BPD-associated pulmonary hypertension. And that means looking at all echoes that they had starting from day 28 monthly until the time of discharge. When we're looking at early screening, which is looking at day 28 until 36 weeks, then you only detect about 78 cases compared to 136. If you do just a singular screening at 36 weeks, you get only 59 cases. And if you do screening after 36 weeks until discharge, you do the late screening, you get 121 cases out of 136. So I think that was very interesting.
Mhm.
When we're looking specifically at the gestational ages at which BPD-associated pulmonary hypertension was first detected in the early screening, which again, for the purpose of this, is defined as between day 28 of life and 36 weeks postmenstrual age, it caught pulmonary hypertension at a PMA of about 35 weeks. When you do the singular screening, it caught it later at about 37 weeks. And obviously, if you do late screening, it often finds it at around 40 weeks of gestation. So that's really, I mean, we're running out of time, but I think that's really it. The conclusion of this of the group is that while obviously BPD associated pulmonary hypertension is something that is evolving with respiratory disease, they identified that late echocardiographic screening as a potential optimal screening strategy, and that this screening strategy in which echocardiographies are done beginning at 36 weeks and that continue monthly until hospital discharge identify a similar number of patients with BPD-associated pulmonary hypertension as a screening strategy in which echocardiographic screenings begin very early, especially as early as like very early in the course of the hospitalization. Moreover, there's a lot of cost-effective, this probably represents a cost-effective approach without compromising the number of babies that you can actually identify. And there's obviously more evidence that is needed to corroborate these particular findings. So I think this was very interesting because it's something that we definitely want to know. I mean, I think that in our, I don't think I know in our unit, obviously we do it at 30, we start screening at about 36 weeks. And I found that trying to screen even earlier is often a very frustrating endeavor because you
Because we
don't
sure do
often,
try.
we sure do try.
Yeah.
That's right. And it's rarely positive.
Yeah.
And I think that it's important for us to know that they had some pretty loose screening criteria for pulmonary hypertension. Because technically, again, if you have a bidirectional PDA or a bidirectional PFO, it seems like you would just be considered to have some elevated pulmonary pressures. So I think that's interesting.
Very interesting. I guess the discussion point really comes like, are there a group of babies that would benefit from treatment of the pulmonary hypertension before 36 weeks? I don't know the answer to that. I don't know that anybody knows the answer to that, but
I think that
it
if you
feels
have
like there is.
babies that have some predisposing conditions that could lend them to become hypertensive before 36 weeks, then yeah, you will find them. But your typical baby that will develop pulmonary hypertension as a byproduct of their severe pulmonary disease, I think it's rare to find them to be having echocardiographic findings of pulmonary hypertension before that particular gestational postmenstrual age mark, because I think that the heart has an ability to compensate for a very
Mm.
long time. So I think that too is something that's interesting, and the non-invasive methods of looking at that, whether it's pro-BNP and so on, probably are not that much
Mm.
better either.
Yeah, that makes sense. I had one more article, but we are way over time. So instead of a full research article, I just wanted to highlight this case report.
Sure.
It was actually in Endocrinology, Diabetes, and Metabolism. It's a journal for case reports. And it's entitled Continuous Glucose Monitoring in a Neonate with Hyperinsulinemic Hypoglycemia and ABCC8 Gene Mutation. Um, I just thought it was an interesting case for a number of reasons. Their background is, I think, pretty good, pretty easy to read, about hyperinsulinemic hypoglycemia. So obviously, we have some transient cases. We see that all the time with infants who are LGA, those who have perinatal asphyxia, the preterm infants. Um, but then there are some babies who have these genetic problems that cause this prolonged hyperinsulinemic hypoglycemia. And the big things I wanted to highlight is so they had this case report of a 37-weeker. It was a G1P0, no major concerns during the pregnancy other than Hashimoto's thyroiditis. The baby came in at 37 weeks in labor, or the mom came in at 37 weeks in labor, and the baby was admitted, obviously, to the NICU, a special care unit, for very low blood sugars, less than 25. And basically continued to have severe hypoglycemic episodes despite they said up to 30% IV glucose infusion. So obviously they got their specialists on board. Lots of medications, octreotide, diazoxide, lots of things to try to recover this infant. And was later found on whole exome sequencing to have a genetic cause for their um, severe hypoglycemia, so their congenital hyperinsulinism. But that's not really what I wanted to highlight. What I wanted to highlight was two things. They documented that in the first 10 days that this baby required 110 heel sticks to document and follow the blood sugars. And I think that's, like, not uncommon. I think we've sometimes put babies on Q3 sugars, Q6 sugars, and sometimes people forget about it even as the sugars are getting better. The nurses don't forget about it, but those people ordering it often forget about it. And then because they recognized that this was gonna be a long-term problem and that the baby was getting so many kind of, skin-breaking procedures, they started the baby on a continuous glucose monitor. So it was a Dexcom G6. They inserted it in the right thigh of this infant, and I think some people will have a question. So the baby was 37 weeks, I told you that, and the baby was 4.69 kilos, so a big baby, and they decided, obviously, to use the thigh as kind of the biggest spot to implant the Dexcom, sensor, but then they were able to follow this baby with continuous glucose monitoring. I just think it's really exciting. I think that, if you have access to it, you've got some really good endocrinology support, that this may be of consideration for some of those bigger, older babies. We know that our bedside glucose monitoring isn't even that accurate at really low levels or really high levels. So for some of those babies, I think it's exciting, as we look to really incorporate continuous glucose monitoring into the unit. Hopefully, we can do it before day 10 on babies who need, like
Yeah, I mean, there's more and more data. I believe that
Yeah.
one of the impact article of the year
Yeah,
candidates for the EBNeo team was one of these papers that we had reviewed as well. So
that's right.
the data is there.
It's coming.
I feel like maybe the tech is lagging a little bit behind because it's not that used as prevalently as we would
Yeah, or
probably
maybe,
think.
I don't know, maybe we're not brave enough to be using
Maybe
it
we're
in
not,
cases where we could be using it given, you know, case reports and
for
not
sure.
not just case reports, but studies, like the ones that
Yeah,
you mentioned. So,
absolutely,
all
absolutely.
right.
All right, buddy. That was great. I will see you next time for another episode of the podcast. We are working very hard for the changes coming to the 2026 edition of the podcast. We are taking the feedback that you guys provided during the end of year survey, and we will have more journal clubs. We will have more easy to access content, and so stay tuned for that. And if you have not secured your spots for the upcoming Delphi conference in January 2026 in Fort Lauderdale, Florida, please go to the Incubator website, the-incubator.org, and secure your spots now. Tickets are selling fast, and we have a great lineup of speakers. So we're looking forward to seeing you all there. Daphna, have a good rest of your day.
Thanks, buddy. Bye, everyone.